Good afternoon, everybody. And just to say welcome to our SAPA webinar. We've got a really exciting afternoon, and we've tried to do a tour around the rest of the country and call it Life in the Times of COVID. So I'm just going to mute everybody, and the speakers can unmute themselves. And just to give you a rundown, we've got Dr. Maureen Marsha from the NICD, who's going to give us a national overview of the pediatric data. We then got Professor Zia Dango from BITS, Christina Desmopoulos, Melinda Makabula from the Eastern Cape, Fatima Nabi from KZN, and if we've got time, then Mayra Rousseau from Red Cross. Okay, so okay, all right, so I just want to see, Maureen, are you with us?
Yes, I'm definitely there. Good afternoon to everyone.
Fantastic, Maureen. If you've got slides, I've made it possible for you to share your slideshow. And we are really excited to have you and to share what the pediatric data is, because I think that's really an interesting topic for all of us. So I'm handing over to you, and the floor is all yours.
Thank you very much. I'm just going to share my slides. Oh, sorry. I think I'm projecting a wrong thing, so. Okay. I'm struggling a little bit. Let me go back. I think I'm ready to present. Thank you so much for the invite to participate in the SAPA COVID webinar. I'm going to present pediatric admissions recorded on the COVID-19 Sentinel surveillance digital platform. I'm going to start with the overview. DECOV was established on the 1st of April 2020. It is a Sentinel surveillance digital platform for COVID admissions, and we usually invite both the public and private healthcare facilities to register on our platform. And some upload their patients directly on our platform, and others send us an Excel spreadsheet daily to upload. So as of the 13th July 2020, we had 288 hospitals in all 9 provinces submitting data of hospitalized patients. 76 were public hospitals and 202 were private hospitals. And as new hospitals join, they retrospectively capture all admissions. So we have all the hospitals from different provinces, the 9 provinces reporting on our platform. And as you can see from this slide, Western Cape has got more healthcare facilities reporting, both public and private, followed by Gauteng, then KZN. And we've got Northern Cape, as well as Limpopo being the ones that are reporting least on our platform. So the admission data summary from the 5th of March up to the 13th of July, we had a total of 23,119 COVID admissions, which were captured on our DECOV digital platform. And of those, 753, which is about 3.3%, of patients, of the total cumulative patients, were patients less than 18 years who were admitted to different healthcare facilities. And 13, which gives us a case fatality rate of 1.3%, died during admission, and 600 patients pediatric patients were discharged alive, and 7 were transferred to other healthcare facilities. And of the 753, only 52 needed to be admitted to ICU, and only 2.4% of those were ventilated at some point during their admission. Now we go to admissions by epidemiological week and province, and we can see that there is an exponential increase in admissions by week, and most of the admissions were in the Western Cape, followed by Gauteng. But you can see that between week 23 and 24, there was a slight drop in admissions. And the reason being, one of the private healthcare group couldn't submit their data because they had IT challenges. And when we go on admissions by age and sex, also from the same date, 5th of March to the 13th of July, you can see that in all the age groups, except 15 and 18, the age group less than 7 days, 7 to 28, 29 to 1 year, 1 to 4 years, 5 to 9, and 10 to 14, most admissions were male. And only when we get to 15 to 18, where you find that there's a spike in female admissions. And we also checked the frequency of comorbidities among the admissions. And we found that there was a total of 145. And the commonest comorbidity was asthma, followed by TB past, then HIV, diabetes, and the least comorbidity reported was kidney and malignancy. Now we're going to take the look at characteristic of children who died, and the total was 13. And I'm just going to move this a little bit. There's something, this was in my way, sorry. The first case was a 2-day-old infant male who died, admitted and died on the same day, and was admitted to ICU and ventilated. And the cause of death was reported as hyaline membrane disease due to prematurity. So we took this to be a non-COVID death, though the infant tested positive and the mom was positive, but the immediate cause of death was recorded as hyaline membrane disease due to prematurity. And the second case was a 1-year-old female infant who had an underlying medical condition of dilated cardiomyopathy, was admitted to ICU and ventilated, but died the same day, and had cardiogenic shock as a complication. She also had normocytic anemia, hypoglycemia, and elevated cytomegalovirus viral loads. And the third one was a 15-year-old male who had diagnosed with Prader-Willi syndrome at birth and had hypertension, diabetes, and morbid obesity as comorbidities, was admitted for 3 days in ICU, and other reported comorbidities were hypothyroidism, hypogonadism, intellectual impairment, sleep apnea, and copulmonale. The fourth was a 16-year-old male with acute lymphoblastic leukemia. The length of stay was 5 days, admitted in a general ward, not ventilated, and had received previous chemotherapy. So he was admitted with COVID symptoms, fever, cough, and shortness of breath. and was treated with high flow oxygen, antibiotics, as well as steroids. And the fifth one was a 17-year-old male, and this one had passed TB in 2005 and was admitted to general ward and died the same day. The sixth case was a female, 14-year-old, with congenital mitral valve insufficiency and had a prosthetic valve. Length of stay was 1 day, admitted in ICU, and also had a history of previous endocarditis. And she was admitted with flu-like symptoms and a worsening headache. And when they checked the results after that, they found that she had an elevated INR. So the cause of death was recorded as intracranial hemorrhage due to warfarin toxicity. And the seventh case was a 15-year-old female with malignant neoplasm, and the length of stay was 45 days. And she was in ICU but not ventilated and had pericardial effusion as a complication. She was admitted with non-COVID symptoms and 15 days later tested positive for SARS-CoV-2. And she also developed viral pneumonia and died on the 2nd of July, 2020. The eighth was a 14-year-old male. The comorbidities were unknown in this case, was admitted for 15 days in ICU and ventilated. This one was admitted with symptoms of fever, muscle and joint pains and deteriorated in hospital, but we don't have the full clinical information with this one. And the next one was a 12-year-old male with an underlying medical condition of insulin-dependent diabetes. The length of stay was 13 days in ICU, ventilated. He was also admitted with non-COVID symptoms, but tested positive a few days after being admitted. And the next one was an 18-year-old male who had active TB, was admitted for 5 days in ICU, not ventilated, no further information, clinical information. And we also had a 2-week-old male admitted to ICU and ventilated, but died after 2 days. And even with this one, we don't have further clinical information. And we also had a 2-month-old infant admitted to a general ward and was there for 27 days. We don't have any other information except that this infant was RVD exposed and the PCR at birth was negative. And the last one was an 8-month-old infant with atresia of the bile duct and was previously admitted with obstructive jaundice. And the length of stay was 12 days in a general ward. So those are the clinical characteristics of the 13. And summary of the 13 children that died. The median age was 14.1 with an interquartile range of 1 to 5, 15.9 years, and with 5 infants being less than 5 years. And 8 of those who died were males, that is 61.5%, and 5 were females. The median length of stay was 5 days, and the interquartile range was 1 to 13 days. Of the 13 who died, 8, which is 61.5, had known underlying medical conditions, and 4 had no underlying medical conditions, and 1 had unknown underlying medical condition. The limitation is that with DEDCOV Sentinel surveillance system, we can only capture those admissions that are uploaded on our system, and it's not all hospitals in South Africa. And the data quality depends on what is submitted by the healthcare facilities. Though we do data checks from time to time, but we rely mostly on clinicians submitting accurate data. And we also had missing or incomplete data on comorbidities. And now we've changed on our platform to also check the reason for admission, because we find that not all were admitted for COVID, with COVID disease. Some were admitted for isolation purposes and others due to other medical conditions. And with DEDCOV, we can only record hospital-based admissions, and deaths that occur outside the hospital are excluded. The conclusion is that we had a low percentage of overall admissions in children, which is similar to other countries. We had a much lower requirement for intensive care and ventilation than adults, which is also similar to other countries. And when we do an analysis on the deaths of these children, in most cases, it occurred due to serious and severe underlying medical conditions rather than COVID complications. So these are the hospitals that are reporting on our platform. We've got the private hospital groups, Netcare, Life, Mediclinic, NHN Clinics, LandMed, Joint Medical Holdings, reporting on our platform. And we have quite a number of public healthcare facilities reporting. And we think the number is going to go up now that the Minister of Health has instructed hospitals to start reporting on DEDCOV. Thank you. For inquiries, we've got our email as dedcov19@nicd.ac.za. Thank you very much. Questions or comments?
Thank you very much. From our point of view, that was really very interesting. I must say encouraging to hear that there are less kids, as in keeping with other countries, less ICU and ventilation requirements, and that of those kids who were unfortunate to die, many of them had serious medical comorbidities.
Yes.
I've suggested that you type any questions into the chat box. Maureen, I think if it's okay with you, are you going to be able to stay on and we'll go to the next speaker and come back to you if there are any questions? Would that be okay for you?
That will be fine with me.
Lovely. Thank you very much.
Okay.
So if you could just stop sharing your screen.
Okay.
I'm then going to, thank you very much. Our next speaker is Professor Ziad Dangor, and we thought we would do this as a question and answer session. And Ziad, how are you this afternoon? Are you good?
Good. Hi, Mignon. Good afternoon to everyone.
Fantastic. Nice to see you. So Ziad, you work in Johannesburg, and I thought we would just chat about some questions and some thinking around COVID in children. And I think the first question we're going to ask is, in terms of reorganizing your wards in terms of COVID positive, patients under investigation, and non-COVID, how have you been rearranging your wards?
Well, thanks, Mignon. I think I don't speak for myself, but I think we all have challenges in how we organize our facilities. And for me, the biggest challenge, I think, is space, and all depends on the number of admissions we're having. So what we did at our facility, we initially approached it as a respiratory and non-respiratory sort of split, and thought that we'd get most of our admissions being respiratory. But clearly what the data showed was that a lot of the COVID positive patients did not have respiratory symptoms, and therefore we had to move much more towards a PUI admission ward system. And I think most people have gone towards that kind of system. I think the biggest challenge with the PUI system is that you have to have an efficient laboratory service to give you results timelessly. And if you can get that, then you can move patients into COVID positive or COVID negative sort of pediatric wards. And we've been fortunate in our hospital is that we actually have testing done within 24 to 48 hours. And I don't think everyone else has that privilege. And engaging with my colleagues at some of the regional hospitals, I think you can be waiting for days before you get a result. So the PUI concept works if you can get a lab system on board and get results timeously.
Great, and I must say we've had a similar problem in that many of the children that have come in either with trauma, car accidents, for elective surgery or emergency surgery, we found that they've actually been coincidentally COVID positive. So we've had COVID positive areas, PUIs, COVID negative areas, and then we have those kids that we've also found with COVID unexpectedly positive. So that's been a big issue for us as well. In the Western Cape, they've now decreased the number of cases tested routinely, so just healthcare workers and people over the age of 55, and that has made our waiting time much less. So we similarly had a waiting time of up to 4 or 5 days, and now we've got it down to about, like you, sort of 12, 24, 48 hours, and I think that makes a big difference in terms of rearranging it. Have you seen a nursing crisis, Ziad?
Yeah, so I think one of the hardest hit areas have been the nurses in terms of healthcare workers becoming infected. And certainly we've seen it, and I'm sure everyone else has seen a similar situation where healthcare workers, and I'm sure it's across the board, nurses as well as doctors, but where I think pediatrics is struggling generally is that we know there's a nursing crisis anyway in South Africa. And if you ask me, I would say they're the rarest commodity in the health sector that we have. And now COVID goes and knocks out a whole lot of nursing staff, and that is challenging in terms of care for our children. So I think that's just compounded the problem to a large degree.
Yeah. Something else we've learned as we've gone along is that often our staff have not acquired COVID from within the hospital, within the wards, but more in tea rooms and in the community and in the taxis coming to work. So we've kind of called it tea rooms and taxi buddies. And the time where masks down and people are drinking coffee and tea, we've had to look at our tea rooms and either try and close the tea rooms or in fact decrease the number of people per tea room, because this is where we found that people have picked up this condition as well. So what have you done with your students? Because you work in a teaching facility, and obviously we want to try and keep students learning, but what have you managed to do with your students?
Yeah, so I think that's a really good question, Mignon. I think what we're going to see is probably a knock-on effect in terms of the training of medical students. Certainly the mandate had gone out that the final year students had to return fairly early, and that the importance of that was to get them trained so that interns won't be lacking next year. Unfortunately, if you look at the conventional clinical teaching bedside tutorial mechanism, that cannot happen in this sort of COVID environment. And even if we're testing children and we're finding that they're testing negative, we know that there is obviously the false negative rate, and therefore students also have to protect themselves like everyone else. I think what makes students special is that, and I'm using the word special, is that they often don't have access to the healthcare that we have as healthcare professionals. Most students rely on some sort of loans or bursaries, and I think that does make it challenging when they don't have medical aids. And we're asking them to come and work in a hospital where they are at risk of disease as much as every other healthcare worker. And I think the other thing that makes students vulnerable is that we know there's the PPE supply shortages, and the question is how much of that can we provide for our students. So we've had numerous challenges. I foresee that we're going to have a significant knock-on effect the longer this happens. I'm sure most academic centers are going to find the same. The closer the student is to getting or qualifying as a healthcare professional, I think the less of the knock-on effect. But the younger years in the clinical space are going to find it difficult. We're going to have to do catch-up probably next year, the following year, and those that are in their final years will probably have to do catch-up in internship and community service. So I do think we're going to see a real gap in the knowledge of healthcare professionals coming through.
And I think it really calls for innovative thinking, as you've said. So we've done with our students what a lot of the schools are doing. We've had some students only come for the morning, some students only come for the afternoon. And then we've done quite a lot of online teaching and mentoring and tutorials. But I think it takes a lot of innovative thinking. So Ziad, you've mentioned the nurses, you've mentioned the students, but how do doctors feel? What are their attitudes? How do they feel about the concept of working in the front line and also the effect on their family and their friends?
Yeah, I think I would love to hear what everyone else feels, but my sense is that doctors are, and this is normal, I think doctors are afraid to some degree. If you're not afraid for your own life, you're afraid for everyone else you love around you. And I think that if I hear people's sentiments on the ground, people are afraid of being hospitalized, are afraid of having their loved ones hospitalized and being the vectors of transmission for that. And what we're finding is, I mean, there's a whole array of behavior patterns that are emerging. And I think none of us have lived through a pandemic, so we don't really know how to go about this. And we're going to find these challenges. I think the anxiety levels are high. I always give the analogy of we normally have a baseline stress level as healthcare workers or as doctors. And let's say for argument's sake, if you put stress on the y-axis and time on your x-axis, you'll find that you probably float around 20% of stress, you know, in terms of your proportion of stress. And you may have spikes. Every now and then you have a spike. So for example, you lose a loved one or you have a traumatic event and you spiked about 50% or 60%. Sadly, COVID has put our baseline at 50, 60%. So now when we spike to 90% stress levels and so forth. And I think we are in difficult times. I think being on the front line, people are feeling vulnerable. And there's a whole lot of people that go out there, you know, selfless and trying to help as much as they can. And that's lovely to see.
So just from a Cape Town point of view, because we've had quite a lot of patients and staff, a lot of staff being positive, we've tried to look at getting scrubs or clothes that folk can wear at work that's different to what they'd wear at home. And we've also looked a lot at people's mental health and just being kind to yourself. And so we know, as you say, they're big spikes and you feel like there's a large underlying level of anxiety at all times. So I think for me, the biggest message through all of this is really just take time and be kind to yourself as well. And in that kindness, what do you feel people have done when the adult colleagues have asked for help? And what do you think our role and responsibility is as pediatricians when our adult colleagues are actually asking for help?
So I think that call has been made, and I would love to hear what other people think, but we certainly have got the call from our adult colleagues saying that as a pediatric department, we are relatively quiet. And there's no doubt our admissions, and I'm sure this is across the board, pediatric admissions have really dropped. We didn't see the usual RSV peak that we normally see. Certainly other infectious diseases are down as well, and the wards are generally quiet. And even though we have COVID patients in pediatric wards, it's nowhere close to the adult wards and the challenges they're facing at the moment. So we've had the call, and I think we need to heed to that call. The anxiety comes in when we're asked to function as adult physicians, when we're so used to functioning as pediatricians. And people say, I've not treated, for example, an acute MI. What do I do? And I think the adult colleagues are saying, look, we have to hold your hand, but we just need the very basics. We need people to just run around and do simple things like take bloods and book kind of things and examine fairly straightforward pneumonias and those kind of things. I do think it is challenging, and I think we have to individualize the situation. And if we can help in any way we can, we should try to.
That's great. And so what we've also tried to do is decant a lot of pediatric patients to our hospital. So where there are hospitals that have adults and peds, we try to take the peds through casualty straight to Red Cross, take all the red cases, so that the adults have more space rather than putting adults into a pediatric ward or facility, we've tried to decant even adolescents that normally we wouldn't take. We've actually said we're better at looking after adolescents. So that's kind of what we've done. So just to share with you, in our setting, we've had quite a lot of staff. I think our latest tally is 141 members of staff at Red Cross that have been positive, but 97 are fortunately back at work. We've had 119 patients, but currently only 4 as inpatients at the moment. So, and when I say positive patients, those may be incidental, as I said, who are tested before they go to theatre. So Ziad, as somebody who's commented in response to how a doctor's feeling, one of the medical officers, I'm just reading from the chat group, yesterday said she's so excited to be part of making history. She's so excited that she will be able to tell her children and her grandchildren that she lived through this pandemic of history. So I think that's a rather charming way of actually looking at it. Any final comments, Ziad?
No, not for me at this stage.
Thank you very much, and thank you for chatting to us. Really appreciate that.
Sure.
So our next speaker is Despina Desmopoulos, who works at the Donald Gordon Medical Center belonging to WITS in a private facility. And Despina, I think from you speaking on a private practice perspective, including the fears of going back to school, which has become a very political hot potato. How are you this afternoon?
Hi, thanks, Mignon. Thanks for having me chat. Have you given me, can I share a screen?
You can share your screen.
So I'm just going to share some of the chats I had with some of my private colleagues, and then we can discuss the going back to school. Sorry, just.
And while you're doing that, I think for us, it's been a really exciting time in pediatrics, because both from a South African Peds Association as well as the Pediatric Management Group, the private pediatricians, we've really pulled together and had some really interesting discussions and supporting each other. So not all is bad in COVID, and I think it's really helped people to share together, think together, and come up with innovative ways of working together.
I have to agree with you, Mignon. I think the way people have started working together is absolutely amazing, and I've really enjoyed the interaction that we've had as pediatricians across the country. So what I've done is as Mignon said, I work in a private hospital, but I just contacted a couple of my colleagues over the last 2 days and last week just to find out what's happening in all the different private hospitals. I was very interested to see Maureen's presentation with 212 private hospitals that are providing data, which is absolutely fantastic. The pediatricians that I spoke to were only in about 25 hospitals, but I spoke to members of the EXCO from the pediatric management group, and so the feeling I got from those 25 hospitals is what's generally been going on around the country. So in pediatrics during the COVID pandemic, the general pediatric practices throughout the country have dropped by 40%. So there are, as Ziad was saying, less admissions in the hospitals, but also in the outpatient departments, practices that were seeing maybe 20, 30 patients are seeing maybe 5 patients. Most of the patients that have been seen that are COVID positive are asymptomatic, and often they are coming to be tested because their parents have been tested. So they are mostly asymptomatic. The symptomatic patients that are being seen and managed as outpatients are usually better in 2 to 3 days. And a lot of our colleagues have seen COVID positive moms and attended cesarean sections with COVID positive moms. But generally, all the newborns are okay. When I inquired in terms of testing, the majority of our colleagues aren't actually testing the newborns unless they're ill. And those that are testing are finding that majority of the patients are negative. Mainly also a horizontal transmission. So the outpatients were the majority, and the pediatricians, the general pediatricians in private practices have generally seen between 6 to 10 patients each, mainly in Gauteng in the last month. and then obviously Cape Town was a little bit earlier than that. The ranges of the ages are mainly between 12 days of age to about 10 years of age, and the symptoms that the patients that are symptomatic are mainly having fever. That's the number one. There have been some episodes of acute gastroenteritis, 1 or 2 patients lethargic, a lot of sore throats, blocked noses, and some body pains. The admissions that were discussed with some of our colleagues, there were a few respiratory admissions, but a lot of the admissions were not respiratory, which I think is quite interesting. There were some incidental findings, so a child with a broken arm, or a child with a gastroschisis, a child with an appendicitis who happened to be COVID positive. There were 2 DKA admissions to ICU, newly diagnosed DKA, and on older kids, which is similar to what our adult colleagues are seeing. A couple of acute gastroenteritis, which resolved quite quickly. 1 child with a febrile convulsion, another with a foreign body and tonsillitis. The comorbidities of some of the kids that are being admitted, there was 1 CP, quite a few asthma, and 1 or 2 cardiacs. Sorry, I seem to have missed my Pimp Cs slide. Sorry, so I think it's somehow disappeared. So just in terms of Pimp Cs, I got history from the private guys that there were about 6 cases, 2 of them in ICU, 4 managed in the ward, and all actually did quite well. So there might be a few more. Obviously, as I said, I didn't speak to everybody, but the private paediatricians are seeing the Pimp Cs. And yes, they're getting the cardiologists involved. The kids are responding fantastically to polygam, and 1 or 2 patients have been treated with steroids, not much more than that. In terms of the morbidities, the mortalities, sorry, that slide's also missing. There was 1 child, a microprem, whose mom was COVID positive. The child tested ×2 negative, but died, and most likely from prematurity complications. But in general, there haven't been a significant mortalities in the private sector. Interestingly enough, a lot of our colleagues are seeing other symptoms, so a lot of COVID toes or chilblains, lots and lots of that, and a lot of anxiety in children and in parents. One of my colleagues explained to me that he had a lot of kids that were anxious about going back to school, and in their practice they actually put our SAPA statement that we published a while ago, and parents have been taking copies and children have been explained. And so there are other issues that are not directly related to the actual disease. Stop sharing. So Menyan, that's just basically the chat that I was having with colleagues in private. As I said, it's in no way complete, but it is giving us a feeling about what's happening in private practice. So on average, maybe 1 or 2% are being admitted, many in the outpatient department, but generally all patients are doing well.
That's great. Thank you very much for that. We've got a couple of questions in the chat box. Why are people not going to hospital and clinics? Because you mentioned that your private practice rate was down by 40%.
Yeah. So a combination of all of the above. So actually, a lot of the medical aids have not run out, whereas they normally are at this time of the year. So it's not so much that they can't afford, it's a lot that they are scared. So many people are scared and are not taking the patients to the hospitals, and they are worried about taking their kids. There was a stage where they didn't want to.
Sorry, Despina, I've muted you by mistake. Do you mind just unmuting yourself?
I've unmuted myself, thank you. So parents have been scared, so they haven't taken their children for their usual immunizations and concerned during the lockdown. what the pediatricians are also saying is that there haven't been the usual diseases that we see this time of year in winter because of all the quarantine as well. So there isn't the usual RSV and the usual bronchiolitis that hits us in winter. But the other checks, like the well baby checks, have also decreased. I think what's happening is people will only come if it's necessary, and they're scared otherwise, and they're staying at home. So mainly the anxiety, I would say.
I think for me, the concern is that a lot of kids are not going for their immunizations, and something like measles, which is far more contagious than COVID, needs a very high herd immunity, and there are concerns that the sort of global immunization status around the country is decreased because of that. Yeah.
So I'm just looking at this kids with chronic conditions, diabetes, asthmas, because they're not able to get their refills on time. The asthmatic, so the diabetes, those who were newly diagnosed due to the COVID, the asthmatics are they're not all just to the fact that they haven't gotten their refills. I think that asthma is probably a comorbidity, but I think the fact that they are actually being controlled is the reason they're not landing up in ICU. So I know that a lot of private pediatricians have started speaking a lot to their parents and going onto social media and advocating for their patients to come and be checked and to continue their treatment for their chronic conditions. Any neonates seen in private with symptoms? Yeah, so the 12-day age was what was seen in the outpatient, so in the rooms, in the consulting rooms. But there have been neonates being admitted in the neonatal unit that have been positive. But the general feeling is that they're not actually sick. There was that microprem that they were suspecting is positive, and that child died. But the patients are actually, the neonates are actually not ill.
And then I see the final question is, we've seen a strange cohort of very young, less than 3-month patients presenting with gastro and a hemolytic uremic-like syndrome picture. My colleagues in London have definitely seen that. We have seen a little flurry of what we call pediatric inflammatory multi-system disease, or PIMS. Despina alluded to it and showed some pictures, but these kids have on the whole presented with gastro, fever, red eyes, sometimes red lips, so a Kawasaki-like syndrome, and a lot of them have had cardiac involvement as well. But on the whole, most of them have actually presented with GIT symptoms. And if they've had abnormal echoes, they've actually responded very well to immunoglobulin and to steroids. And we actually did present this a few weeks ago at one of our SAPA webinars. And then a mental health point. Do you want to take that one, Despina?
Yeah, so that's exactly what the pediatricians are saying, that they are seeing. So I'm sure what the pediatricians are seeing is what the GPs are also seeing, is a lot of anxiety in the older kids. Yeah, and there is anxiety about going to school, but there's also anxiety about dying from coronavirus. And just on a personal note, when I had a close family member who was positive and sick in hospital, my 10-year-old immediately was anxious and asked if he's going to die. So I think they've been told a lot, and they see what we see and they hear what we say. And I have spoken to a couple of psychologists who say we are going to land up with PTSD with these kids in the future. So I think as parents, we just need to, keep, and parents and pediatricians, we need to keep basically comforting our patients and sending them to psychologists if necessary.
And just on that, I saw a study recently in central China, Hubei province, showed that a quarter of children aged 8 to 12 were depressed, which is a very large incidence. And it's kind of part of why we're quite keen to get kids back to school, because of this whole anxiety about sitting at home and just feeling that all your friends may die around you. So thank you very much, Despina. That was really a great presentation. And we're now going to move on to Nomalindo Makubala, who's from Dora and Ginza in the Eastern Cape. Nomalindo, I'm hoping that you can actually share your screen with us and your slides. Are you on the call?
Yeah.
Thank you very much.
Thank you so much.
Thank you very much for joining us. I feel like people have flown in from all over the country. So that's the one good thing about Zoom, is that you can actually engage people from around the whole country, which is really great.
Thank you so much, Mignon. Thank you for inviting me for SAPA. And I would also want to thank my colleagues from Eastern Cape who shared their experiences. I'm finding it difficult to share the screen. I'm using the iPad. I'm wondering if I can load it in a
I'm going to try and just, if you guys just bear with us, we're just going to quickly try. Did you send it to Beira on her email?
Yes, I sent it to Beira on email.
Okay, guys. I'm wondering if we should ask Fatima Nabi from KZN. Are you on the call? Sorry, and the reason I'm sounding a bit vague is we've got 280 people on this call, so it's really great, but I just want to check that. Fatima, are you on the call?
Hi, I am.
Do you have slides, or were you just going to tell us about your local experience in KZN?
I do have slides. I can try sharing them.
Okay, so Melinda, do you mind if we do Fatima's first, and then we'll try and find your slides? Is that okay?
I don't mind.
Fantastic. Fatima, so thank you very much for joining us from KZN. Are you able to share your slides? Fantastic, there you go, great.
Okay. I'd like to try to thank the organizers for the invite to give our KZN experience. On the onset, I'd just like to say that this this presentation is basically on the public health sector and not on any data from the private sector. Before I commence, KZN is divided into 3 health districts, and I'm just want to mention this briefly because in my presentation I might just allude to areas. So Area 1 it covers the coastal regions. Area 2 is the western part of the province, and Area 3 covers the northern parts of the province. Just a quick highlight from the KZN situational report from July to 21st of July. KZN has 2,067 new cases, and the province contributes to 25% of the new cases that are reported nationally, and we continue to be the 4th highest in the country. Our surge continues in 2 of our areas. eThekwini is in Area 1, and the Umgungundlovu district, which is in Area 2, and they record to about half of the daily cases. KZN also records 18 new COVID-related deaths, and the province contributes to approximately 9% of the deaths countrywide. Now this slide just depicts laboratory-based surveillance data for pediatrics in the province, and it revealed 522 children that were positive less than 18 years of age. And in keeping with the national data, majority of the cases are in children older than 10 years of age. As expected, with the ease of the lockdown levels, there was exponential increases with the number of pediatric cases. And also the number of school cases are on the rise with community spread. And the top 3 districts with school cases are the Umgungundlovu district, Zululand, and Pinetown. This slide basically looks at all of the admissions in the province with our regional and tertiary level hospitals. We had a total of 36 admissions with 44% of the patients less than 1 year of age admitted to hospital, 14% in the age group of 1 to 4 years, and 33% in the 5 to 15 year age category. The following slides just speak to the patients admitted in all 3 of to all tertiary hospital in the three areas. In Area 1, we had 3 patients that were admitted. There was a 3-month-old child who was an ex-prem and was previously admitted to hospital for gram-negative sepsis and hospital-acquired infection, and on follow-up presented with upper respiratory tract infections and was tested to be positive. We had a 6-month-old patient who was actually admitted for workup for prolonged jaundice and presented with a cough, and otherwise there was no other symptoms for COVID. And then there was a 5-year-old cardiac who also on follow-up for his anti-failure therapy was screened and tested positive for COVID. In Area 2, which is the Umgumjlovu district, the tertiary hospital had 4 patients admitted. We had a 6-month-old child that was actually admitted for social reasons. He presented with a cough and conjunctivitis, and because he was admitted, a chest X-ray was done, and he showed and exhibited pneumonic changes. But otherwise, the child was well. We had a 6-week-old that was referred from the district hospital with the pneumonia requiring oxygen. We had a 1-month-old Prim. This is actually a neonate that was tested in the nursery. He actually became symptomatic or deteriorated 3 weeks after being born, and it coincided with an outbreak of hospital staff cases as well as a CSSD outbreak, and was tested and found to be positive. We then had a 2-week-old patient, also a neonate with an anorectal malformation that was referred to for surgery, and he was swabbed at the referral hospital and found to be positive. Incidentally, his mom was negative. So if you look at the last 2 neonates, or the last 2 that I presented, they presented in the neonatal period, but the moms were not tested positive, and we query whether these were actually hospital-acquired infections. In Area 3, there were 3 patients that were admitted. The first was a 7-year-old patient who was a known patient with JIA, who had been admitted for a flare of his arthritis. He then developed shortness of breath while being admitted, and tested positive, and currently is at Albert Tree Hospital, in the room wards. The next patient is a 3-month who's also a known patient to the pediatric surgeons for Hirschsprungs and had developed new abdominal distension. He tested positive with a screening test prior to surgery. And the third patient was a 2-month-old who presented with gastroenteritis and shock and required inotropic support. This patient had a family history of positivity for COVID. Just on that, from all admissions in the province, none of the patients that were COVID positive required ICU admission or ventilation. We had 1 death in the province, and this was at a regional level hospital. A brief summary. It was a 5-month-old male who was admitted for approximately 10 days, HIV infected and diagnosed at birth, but defaulted therapy. And when presented for admission, presented with a viral load of over 6 million. A brief problem list from this patient. He presented with encephalopathy. He had a history of TB exposure, but no documentation of receiving prophylaxis. And in this admission was also being empirically treated for TB meningitis as he presented with seizures. He also presented with severe diarrhea and vomiting and was treated as dysentery with hypovolemic shock. Also a community-acquired pneumonia. This was COVID positive. In his admission, he had a hepatitis. There was a differential of whether this was actually drug-induced, but a lab result showed that he had a hepatitis B surface antigen was positive, and he had failure to thrive. So his progress, initially he was stable on nasal oxygen, and then had an acute deterioration a week after admission. He was hypoxic but stabilized on a rebreather mask. Then day 9 post-admission, he presented with GE and shock, and at this point, requiring a nosocomial infection and demised 11 days post-admission. So there's 1 pediatric one pediatric death for the province is totals to 0.3% of the total deaths of our province, and yeah. So if we have to discuss healthcare worker infections, we are seeing an increase in healthcare workers becoming infected, as hospital infection admissions are also increasing. And although there's a limited number of pediatric admissions, healthcare workers are on the rise. We had one death amongst the nursing staff in area 2. What was noted is that we have cluster outbreaks in units. As in other provinces, we're addressing the tea room issues and trying to maintain distancing in this time, reinforcing symptom tool monitoring and making sure that staff are testing when they are showing symptoms. And we're trying to respect confidentiality. We're still trying to strategize risk exposure with the hope of having to contain spread among healthcare workers. In Area 2, our tertiary hospital currently has 10%, or overall from the time we have exhibited or showed that we have healthcare worker infections, we have seen 10% of our staff being infected. We have with having 55 recovered, and we currently have 7.5% of our total staff being infected at the hospital. We had a total of 37 doctors being COVID positive, 99 nurses, and 23 support staff. So the challenges that we're facing in the province is laboratory turnaround time. It takes approximately 5 to 7 days for us to get our results, but this has been or is currently being addressed, especially in Area 1, so in addition to the automation test that's currently available, there's going to be the introduction of the extraction and amplification process and a biofire test that would run a few tests for urgent cases. Also, to address this situation of the turnaround time, more staff are to be employed at the laboratories. So that has been addressed. The second problem that we have is that there's no isolation facility to accommodate patients less than 16 years, and ongoing discussions are currently still being held to address these problems. And that's it. Thank you. Any questions?
Fatima, thank you for a very lovely presentation. You've obviously put a lot of work into that, and I think it just mirrors all the problems that we have around the country. I think you're addressing your tea rooms, because there's definitely clustering of staff. And we've seen the bounce back in the Western Cape, where a lot of the staff feel that the pandemic has now gone to other provinces, and so everybody can relax, and they've started having parties and baby showers and all that kind of stuff, and so staff are now becoming infected again. I think your comment about staff confidentiality is always a very important issue as well, and it's a real toss-up between confidentiality but also allowing staff to realize that this really is a real problem. I think it took a lot of our staff a while to realize that, and also the concept that we all have, that this will never happen to us until it happens to us. So thank you very much.
Welcome.
Okay, so I'm not seeing any questions in the chat box, but I think this is very real, and the issue we've had is in terms of children is, do you allow parents in as well? And so in the adult hospitals, you're not allowed a relative to come. In the children's facility, we've actually allowed a parent to be there at the bedside. We've tried to encourage that the parents stay, they don't swap around too much, and to limit exposure, but we've just felt, and we've as SAPA have also felt that in private facilities, there should also be a child, should be allowed a carer in terms of an adult carer, be it a parent or an aunt or somebody, to be at their bedside as well. Okay, sorry, just a quick question. How did the excellent presentation, how did the 5 neonates do?
I can speak for the 2 that are in my district or my area. They're actually doing quite well. And the one prem is just awaiting weight gain and then will be discharged. Yeah, the other patient is currently still being admitted because he's it's social reasons. Basically, they're unable to isolate at home, and that's why he's still being admitted to the hospital.
Great, thank you very much. Okay, so Nomalinda, you're up next, if that's okay with you. I'm just going to try and share your presentation. Can you see that, Nomalinda?
Yes, I can see the presentation.
Okay. I'm not sure that you'll be able to change slides. If you just ask me, I'll do that for you. So just to introduce Nomalinda, she works at Dora Nginza in PE in the Eastern Cape. And it's great to have you on this call as well.
Thank you, Milan. I'm not sure if I can start, if people can see the presentation.
Yeah, okay.
Okay. So the first thing is that for Eastern Cape, we are saying that the vulnerable population is almost lost and forgotten in the dark forest of COVID-19. They can't see the slides, Milan?
You can't see them. Sorry, I thought you said you could. Okay, let's just bear with me. I don't know what to do. Can you see them now?
No?
Still not.
It's fine. If you can't find the slide, I can talk without slide.
There we go. Can you see them now?
Yes.
Okay. Okay, there we go.
Yeah. So the vulnerable population almost lost and forgotten in the dark forest of COVID-19. This is how we feel. Mainly it's because of the science of COVID-19 and the disease nature when it comes to pediatric population. Also the lack of community interventions and compromise of children's health services, and also spaces of care, the lack of spaces of care. We can move on. This is not unique to Eastern Cape. In general, there's ineffective health system to address the epidemic. So now the COVID-19 pandemic has put pressure on the health system. Really for Eastern Cape, there's no proper planning that fits rural areas or in the South African context. Next slide. So from this slide in Eastern Cape, we have 4 regions. The Western region, which is Sarah Baartman and Nelson Mandela Bay Health District. The biggest hospital there is Dora Nginza Hospital. And in Central region, which is Amatole and Buffalo City, with the biggest hospitals being Frere Hospital and Cecilia Makiwana Hospital. And we have Chris Hani and Joe Gabi, which is the Northern region, with biggest hospital being Frontier Hospital, and they also have Alwan North there. And then we have Eastern Region, which is Alfred and OR Tambo, where the Nelson Mandela Central Hospital is, and we also have Mthatha Regional and also St. Elizabeth hospitals. So you can actually see that even though we have this kind of regions, but we end up having inter-region referral pathway, which becomes a challenge with the issues of EMS. We can move to the next slide. So looking at the health system and our experiences as Eastern Cape, I will start with human resource. We have staff shortage, and now with the COVID-19, as much as, for example, in certain areas, there has been staff that has been employed for COVID-19, but that staff came in a system that is already deficient with a lot of vacancies. So that staff got swallowed by the vacant posts and didn't really yield the results that we wanted for COVID-19. And that is one area. And the second part of that, we have other areas like SFRE, for example. They have the little COVID area, but with no COVID staff, even in Dora. And we also seen the increased risk of infection in healthcare workers, and also the burnouts and the anxiety. And the anxiety now is more merging. And one of the reasons that is causing that is that as Eastern Cape, you find that now as a staff, we have to compete with the public for a bed when you are actually sick and need admission. There's also a lack of skill and experience in those who are placed in pediatric wards. And then in terms of infrastructure, there is no physical space, especially for neonatal and kids wards, and no isolation areas. And there's also a high number of PUIs due to the fact that there is a delay in getting the results from the lab. It has improved a bit. At some stage, the lab had about 10,000 backlog, whereby 3,000 was urgent specimens. And now the waiting period was more than 7 days, but that is being addressed. Looking at the medical supplies, the PPE, the issue of PPE keeps on coming. I'll make a live example even now. When you speak about FRE, they do not even have the ordinary non-sterile gloves to use on daily basis. In some, and then the other big one is N95, which we do not have. We're using the KN95, which has no proper seal, which is not conducive for, especially for ICU areas. When we look at leadership, especially at facility level, most of the people, they are acting managers, and which means that comes with a lack of accountability, and sometimes they are not visionary the way we would like them to be for pediatric setting. Okay, next slide. So before that, now when we look at the experience in Eastern Cape, the focus has been on adult high care and ICU approach instead of community interventions, and also the commander approach in dealing with epidemic instead of involving the clinicians' expertise. That thing of being told that this is what you need to do without finding out on people what can they do and how do they want to approach the problem. And the collaboration approach is really not based on science, but is political driven, which makes it to be ineffective. So human resources, as I said, there's no staff dedicated for COVID. But with all this, in summary, for Eastern Cape, there's lack of preparedness and focus in pediatrics. There's also a risk of death from preventable diseases, and also we're facing a risk of outbreaks due to the poor immunization coverage and also management of other pediatric conditions. Like, for example, if you look at our bed PCR testing, it has dropped, and also even the patients are not even fetching now the ARVs, is because everyone is driven to the COVID. So that is the experience in Eastern Cape. Thanks. Thank you.
Thank you very much, Normalinda, for being so honest and for telling us about the challenging time you're having. I think often when things are challenging for adults, they're even more so for children. And that is obviously a concern. So just looking at the chat group, there was a question for you. Do you know how many children in the Eastern Cape have been admitted in your facilities, or any ICU or high care admissions? Would you know those numbers offhand? I know it's putting you on the spot a bit.
Yeah. In Dora, they've had ICU admission of a confirmed case, but that admission, the patient did well, was discharged. And also in Tata, in Nelson Mandela Central, they also had one ICU admission, and the patient have done well.
Great. And I see Pinky, who's one of the ICU consultants, says in PE only one positive. So that's really good. Okay. Thank you very much. So then our last speaker for the day is Dr. Barry Rousseau from Red Cross, who's going to speak about our numbers in the ICU. So I'm going to hand over to her, and we look forward to your presentation, Barry. Go down there. Thank you very much. Close that. Can you just go?
Good afternoon, evening, everybody. So I am just sharing a bit of the ICU experience at Red Cross, and you can see there on the purple is our dates, and Mignon just discussed it earlier, our numbers for today, 119 positive patients so far, and only 4 in the hospital still. But I think this reflects what we're seeing throughout the country, staff, more of an issue, and that impacts on our ability to provide care for our children. If you look at the slide next to it, is the data of our ICU admissions, and that is now for 14 weeks of the lockdown up until the 30th of June. In the red, you'll see 2020's numbers of admissions. You can see 310 ICU admissions, and comparing in the green and the blue is the previous 2 years for 2018 and 2019. And this echoes what we are seeing throughout the rest of the country. There's 60 odd patients less this year that we've been admitted. And the question is, where's all the kids gone? And I think this is similar what we see in the rest of the world. If we look at our medical admissions in ICU for the 14 weeks, you can see that we're having less medical admissions and typically less sepsis and less lower respiratory tract infections or pneumonia. And we think this is related to social distancing and less RSV influenza spread at school. But we're seeing slightly more cardiac admissions and a little bit more HIM-ONC admissions. Our ICU is a medical and a surgical ICU, so post-op surgery patients also get admitted to our unit. And what we can see for our surgical admissions is very similar numbers throughout the past 3 years. And again, in red is what we see this year. But you can see the big difference is less cardiac surgery patients, and that's because we've stopped any elective surgery. We're just doing emergency and semi-elective surgeries. Then you can see no transplants happened this year so far in the lockdown period. And then our neonatal abdomen admissions, and this is typically your NEC babies, that's slightly up because this is emergency admissions, or your congenital surgical patients with gut atresias or congenital abnormalities. If we look at our trauma and accident admissions, we've got a marked increase in burns admissions this year, less poisons, and very similar trauma patients that we admitted. And then lastly, looking at our mortality, and we've got an increase in cardiac mortality in red there. And I think this can be related to less cardiac surgery, so there's more complications, but this is also children coming in with non-surgical cardiac conditions like cardiomyopathies. There's a bit more trauma mortality, but you can see again a reduction in the pneumonia mortality and the sepsis mortality compared to the previous 2 years. And if we look at overall mortality, for this year in red, our mortality on average is 8.3% for the 14 weeks, compared to 7% for the previous 2 years. So in spite of seeing less children in ICU, we're having a high mortality. And just something on our trauma admissions. We've had 2 children die of gunshot wounds in our trauma emergency area, even before getting to ICU, and 1 motor vehicle accident child die in the trauma unit. In ICU, we've had 1 assault child die, 1 motor vehicle accident death, and then 1 pedestrian vehicle accident death. But if we look at the patients that survived ICU, another 3 gunshot patients, 1 assault patient, 1 motor vehicle accident, and 4 pedestrian vehicle accident, 1 fall patient, and then 1 patient that was mauled by a pack of dogs. And all of these patients survive ICU to discharge, but they've got severe morbidities. And to me, this is a big concern. Having 5 gunshot children coming through our facility in 14 weeks of lockdown, this is a big concern that we are facing in our country. Just looking at our COVID cases coming through ICU, we've had 15 odd cases, and you'll see the majority coming through would be for chest infections, but most of them are actual coincidental findings. So 1 came in, it's a child with some comorbidity with pneumonia. That was our first case. Our second case was a child known with dilated cardiomyopathy that came in peri-arrest and died soon after admissions within a couple of, within the first half an hour. Then we had an oncology patient that stayed with us with ARDS. She needed ventilation for 16 days. Sorry, this was not the oncology patient. This is the CMV pneumonia patient that needed 16 days of ventilation. Then the next child came in with respiratory symptoms, pleural effusion, just high flow. Effusion was tapped, went out, and then came back with a tamponade that got tapped. And then only later we found out that it was actually an oncology patient. So it's not the COVID that brought this patient in. So similar with the next patient came in with a whiteout on the one side, and it was a foreign body. And we had major logistic problems getting the bronchoscopy organized to fish out the foreign body. And he stayed with us 12 days on the ventilator, and it was mainly getting the bronchoscopy organized because it's a high-risk procedure. And once the foreign body was out, within a day we got him extubated. So it was more the foreign body that brought him in than his COVID pneumonia. The next one is similar, a Staph aureus neck abscess going into the mediastinum and needed post-op care, but coincidentally COVID positive. Number 7 was a child that had a superficial burn and came in with sepsis, shock symptoms. We thought it is a toxic shock. patient and coincidentally COVID positive. Didn't need much respiratory support, only high flow. And then the last one, number 8, is our oncology patient with stage 4 oncology disease, and she developed ARDS, didn't ventilate her, and she was our second ICU death from COVID. Then we had another staph sepsis patient coming in with osteomyelitis, coming in for drainage and sepsis, had some chest problems on high flow, went out quickly and then came back with a loculated pericardial effusion post-drainage. So again, staph sepsis, not necessarily the COVID bringing him in. DKA, coincidentally, COVID positive. Then number 11 is a child that had a orthopedic procedure and came back with wound sepsis, stayed with us after surgery for debridement, also congenital heart lesion, and coincidentally COVID positive. Number 12, similar story, appendectomy with a congenital heart lesion, stayed with us post-surgery and coincidentally COVID positive. Number 13, COVID lower respiratory tract infection in a smaller baby, CPAP for 3 days. And then number 14 is a patient that we thought maybe could have been one of our first PIMS or multi-systemic inflammatory syndrome, presented with myocarditis symptoms, abdominal pain, diarrhea, and kidney involvement, and only needed high flow for a few days. And number 15 also came in with chest symptoms, but comorbidities of biliary atresia and abnormal kidneys, and only stayed for a day with us on high flow. So it seems like we've been having a plateau of our COVID positive patients, but what we're now starting to see is our PIMS patients coming in, and we're starting to see more PIMS admissions. And this is the last few of PIMS admissions, and you'll see a very similar picture. It's older children coming in with shock state, fever, rash, abdominal pain, some diarrhea, some acute kidney injury. And the third one there, we gave some IVIG steroids, needed ventilation for 4 days, and she actually got some tocilizumab because the inflammatory markers didn't improve on the IVIG and steroids alone. Next one, very similar picture, but some coronary dilatation, needed 3 days of ventilation and some dialysis, got IVIG and steroids, and was discharged from ICU after 7 days. Number 5, very similar story, also dilated coronaries, but only required high flow and received steroids and IVIG. Number 6, very similar picture, only IVIG, didn't need any ventilation support. Number 7, again, needed ventilation for 2 days and dialysis. Typical picture, myocarditis, shock, fever, rash, acute kidney injury, and also a pleural effusion that we needed to drain. And then the last one came in with appendix, query appendix, abdominal pain, conjunctivitis, myocarditis, shock, and again responded well to IVIG and steroids and was discharged after 1 day in ICU. So this is basically what we have been seeing now more commonly than our COVID positive patients. So for me, in summary, is definitely less medical admissions and specifically lower respiratory tract infections, and that is similar to the rest of the country, but overall increase in mortality, and that's mainly trauma patients and some of our cardiac patients with comorbidities. Only 4.5% of our ICU admissions over the 14 weeks have been positive patients, and of our mortalities, only 2 have been COVID patients. So majority of our COVID patients come in for other reasons than the COVID disease. And I think that should be our message, that our children should have access to healthcare as normal, because it's not the COVID that causes the problems in our children. It's non-related normal childhood diseases and then trauma that's causing problems to our children. So we put out a strong message that our pediatric resources should be ring-fenced for pediatrics, because our children are getting affected by normal childhood diseases and then problems like trauma where there's supervision issues. And I'm going to end there. So if there's any questions, please put it on the chat box.
Thank you very much, Bara. That was really great. Lots of work in putting all those numbers together. So questions. Despina, what was your second death?
So our second death was our oncology patient that had stage 4 oncological disease and came in with a chest infection. We thought COVID, but on post-mortem biopsy, there was metastases in the lungs. So that was our second death.
Sorry, so I was actually, I got that, thanks Bara. I was actually asking one of the doctors who put on the chat that in East London,
yeah, okay.
they had 2 deaths, and one with GBS and the other one with gastro-pneumonia. Just interested in that.
Yeah, very interesting, okay. Are you using pulse methylpred or oral pred for the PIMS patients? I think it depends on how sick they are. If they're really sick, if they're in ICU, then they tend to get methylpred and polygam. Otherwise, we have used oral pred, and we've also used oral, IV dexamethasone. So I think it really depends. The PIMS TS patients, were they COVID positive or past COVID? They were pretty much all negative. I think one of the 13 was positive. The rest have all been negative, but many of them have had exposure or have been positive in the past, or have had a family member that have been positive in the past. Thank you for the last slide. Children are dying due to other diseases than COVID. That's very much the case. What's the overall COVID-19 positive admissions outside of PICU at Red Cross? I think, as we mentioned earlier, I think there were 119 cases who admitted to Red Cross in total. And are we using dexamethasone for COVID pneumonia? The answer is yes. So I really want to just thank everybody. I think it's been a really interesting session. I've definitely enjoyed chairing it very much. It's been interesting. I've learned a lot. I think from a school, going back to school point of view, as SAPA, we are still saying that it is a parent's choice to decide if you can keep your child safely at home, educate them, nourish them, psychologically keep them calm and happy. We said that if you are a responsible parent or adult and you do not drink alcohol, and you choose to keep your children at home, in the Western Cape, there is a 3-pronged approach. You can either do homeschooling and deregister your kids, or you can keep your kids at home, or you can send your kids to school. And interestingly, in the Western Cape, I found out this afternoon from the Minister, Debbie Schaefer, there are 1,000 schools that offer meals. And to date, 2.5 million children have experienced hunger in South Africa. So that makes it extremely difficult. We also understand the anxiety of the teachers around kids going back to school, but also the teachers who possibly are at risk. There's been lots of discussion that nursing staff, cleaning staff, portering staff, medical staff are also all at risk as well. And so we really need to adapt and keep our masks on, keep our hands clean, and practice social distancing. I don't think we have all the right and wrong answers about going back to school, but I think as pediatricians, it is our priority to try and make sure that children get education, are safe, psychologically remain calm as possible, and don't suffer from the abuse, the shooting, the car accidents that we've actually seen in large numbers once lockdown has been lifted. And the debate, I think, is can you open an economy but keep your schools closed? So if parents go back to work, what happens to those kids if they're staying at home? And we've seen some really, really bad accidents as a result. So that is something possibly for another webinar. But I just want to thank everybody from around the country. Please keep up the good work that you're doing as pediatricians. Please continue to be advocates for children, because if we don't, then nobody else will. And we really just appreciate everything that you're doing. Thanks to the speakers. Thanks for all the effort you've put into it. And thank you for the 280 people that dialed into this webinar. It's really exciting to know that there are that many advocates for children's health in this country. And I wish you a good night, and stay safe and keep wearing your masks. Thank you very much, everybody.